Okay, and welcome to the Davies Use Case webinar being presented by the Center for Addiction and Mental Health on Buprenorphine order set and rapid access referral. This is a Davies Award-winning use case for the value of health IT. My name is Arnold Simmons, and I'm the Manager of Quality and Patient Safety at HIMSS. It's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and the information and technology enable patient safety tool for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information technology to improve patient outcomes and value. Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information technology-enabled care delivery. So it's my pleasure to welcome our speakers for today's webinar. First, we have Damien Janukovic from the Vice President of Information Management, the Chief Information Officer, and the Chief Privacy Officer at the Center for Addiction and Mental Health. And then we'll have Dr. Brittany Pointer and Christine Bucago present on the Davies use case. Damien, I will turn the presentation over to you, and you can begin when you're ready.
Hello, my name is Damien Janukovic. I'm the Vice President of Information Management, Chief Information Officer, and Chief Privacy Officer at Center for Addiction and Mental Health in Toronto, Canada. It is my pleasure to introduce our Davies Award-winning case studies. A few words about CAMH. The origins of CAMH can be traced to the Provincial Lunatic Asylum, which has been formed in 1848. And since then, CAMH's history has reflected the evolving societal and scientific view of mental illness and mental health. In fact, CAMH has often led the transformation. The history of modern CAMH starts in 1999 with the merger of 4 founding organizations, some of them with a clear focus on clinical care, others with a focus on research. Our transformation continues. As you can see on the slides here, we've been building beautiful modern facilities in the heart of Toronto and delivering modern set of services to our patients. But who are we now? We are the largest mental health and addictions hospital in Canada. We're fully affiliated with the University of Toronto. We do lots of research all the way from basic science to epidemiology, and we do consider ourselves to be a world leader in brain science. We have 3 main sites in Toronto and about 30 locations in Ontario. And we deliver a large number of services, including emergency departments, inpatient treatment, day treatment, and partial hospitalization models. Just in terms of some numbers, just to give you a scale of our operation, we see about 35,000 unique patients every year. Some of these patients are quite sick. As you can see, we see a large number of schizophrenia, spectrum, and other psychiatric disorders, as well as substance-related and addictive disorders. In terms of staff, we have more than 3,000 staff, and we educate the next generation of mental health professionals. Our research has been growing exponentially in terms of both output and the value of grants awarded. Our clinical programs have really 4 different areas: acute care, complex care and recovery, as well as child, youth, and emerging adult program. Of course, we also have a number of clinical services that support those major areas. Over the last 6 years or so, we've been on a real journey of transformation into a data-driven organization. That journey started off with a complete IT infrastructure refresh and optimization. At the same time, we have undertaken a lot of standardization work of our clinical processes, as well as administrative processes, including centralized intake, which has prepared us very well for a clinical information system transformation. About 4 years ago, we went live with a fully integrated clinical information system, which has replaced the previous very hybrid model. We had a lot of paper-based processes, as well as a number of semi-integrated systems. We decided to go with a big bang approach and essentially ripped all of them out on one day and have gone live with an integrated system in the same day. One of the things that we've done really well is that at the same time as we were preparing for our clinical information system launch, we've spent a lot of time building our enterprise reporting as well as business intelligence infrastructure. Hence, very, very quickly after going live, we were able to produce data and show to our clinicians the value of the information they were entering. We continued on that journey. We've created a performance improvement team whose goal is simply to take the insights from the data and drive them into the units and change the performance of the units. We've continued to standardize through and invested heavily into integrated care pathways. And most recently, we launched Krembo Center for Informatics, which we'll touch on a bit later. Here's a high-level schematic of CAMH as a data-driven organization. As you can see, central to our organization is our clinical information system. That data from that clinical information system really feeds our enterprise reporting platform, which we call iManage, which integrates a lot of other data sources. And this is really the source of data where our performance improvement team looks at and generates insights which can then be driven onto the units and works with our clinicians to drive those insights onto the units. As you will see from our case studies, there's been really a lot of really positive, incredible work that has happened through that interaction. We take the data from our iManage platform, de-identify it, and move it to our neuroinformatics platform. Here, we join it and integrate it with brain imaging data, as well as genetics data and other omics data to create this really multi-dimensional longitudinal records of our patients. And just recently, we launched Krembo Center for Informatics, which really has a critical mass of computational scientists that use sophisticated techniques such as machine learning and artificial intelligence to derive the next set of insights from this longitudinal patient, multidimensional patient record to learn new things about the brain and how we can use that information to advance care through personalized medicine. Those insights are then brought back into our clinical information system to drive next set of performance improvement in care. We were lucky to receive a number of awards on our journey. We're particularly proud of our HIMSS Stage 7 designation, which we have achieved last year. So why the Davies Award? HIMSS frameworks have really guided our decisions around technology since the beginning of our transformation journey. What really resonates with us is the focus on achieving patient outcomes through technology. Hence, the Davies Award is a natural extension of the work we've been proceeding with over the last 6 years. I hope you enjoy our case studies.
Hi, my name is Dr. Brittany Pointer. I'm the Associate Chief of the Gerald Sheff and Shanitha Kachin Emergency Department at CAMH, as well as the Drop-In Bridging Service. I'm an assistant professor at the University of Toronto in Ontario, Canada. We are going to be speaking about our buprenorphine order set and our rapid access referral. Buprenorphine is the generic name for the trade name Suboxone, and the treatment that we use at CAMH is in fact buprenorphine naloxone combination, but we will be talking about buprenorphine as it is the active ingredient, and it also is a shorter name just for our presentation purposes. So this story that we're going to share with you will follow the same 4 buckets. First, we will be identifying our local problem. We'll be discussing with you our design and implementation phase, including what interventions we used, and we'll then go into some detail about how health IT has really helped us to implement this successfully across the organization. And then we'll finish up with a discussion around the value derived, not only cost and the return on investment, but also patient safety and staff satisfaction. So As I'm sure you all know, there is an opioid crisis in Canada, just as there is in the United States. The opioid-related deaths in Ontario have increased from 350 in 2013 to 867 deaths in 2016. On the right of your slide, you'll see a map of Canada, and Ontario, which is circled in red, saw this number increase again to 942 deaths in 2017. This is, in fact, the second highest of any province in Canada, only after British Columbia. However, that number relates to all deaths related to any illicit drug. So for the most part, in the emergency department at the Center for Addiction and Mental Health, we are seeing patients with opioid use disorders who are wanting to stop using. This can, often be because a close friend or a partner has recently died from an overdose. As we do not get ambulance drop-offs at our specialized emergency department, we are rarely confronted with overdose situations. However, we do have naloxone readily available in our emergency department. We've definitely seen an increase in fentanyl users and IV opioid users in the past few years. So if we now turn to the problem identification, CAMH was previously providing clonidine as a comfort measure to treat opioid withdrawal in our emergency department. So an alternative treatment option for opioid withdrawal was identified as buprenorphine. The goal was not necessarily to eliminate the use of clonidine, which still has its place for some of our patients, but instead to increase the uptake of this other safer option of buprenorphine. So why was this important to us? We identified that the new Health Quality Ontario guidelines for opioid use disorders, they established a number of standards which were particularly relevant to our setting. The quality standards that are established by Health Quality Ontario focus on conditions or topics where there are large variations in how care is delivered, or where there are gaps between the care provided and the care that Ontarians should be receiving. So for our purposes, the opioid use disorder standards included administration of an opioid agonist therapy within 3 days of presentation to a family doctor or a community provider. This timeline is reduced to 2 hours when somebody presents to an emergency department in active opioid withdrawal. And finally, the distribution of take-home naloxone kits from emergency departments is also a standard. As the leading academic mental health and addictions hospital, we felt the need to lead the way in best practice treatments for this patient population. Buprenorphine is an excellent choice for managing opioid withdrawal, given that it has a ceiling effect and thus minimal risk for overdose. Because it's an because it is an opioid agonist, it supplies, there's a constant supply of opioid to those opioid receptors, and thus there are the cravings that one might normally experience with illicit opioid use are minimized. So in addition, once somebody is on this medication and are stabilized, if they do use opioids concurrently, those may have a blunted analgesic or euphoric response. Same time. So the next slide goes over our workflow in the emergency department that we were previously using. So when somebody presented to the emergency department, we would engage them in a discussion about, their withdrawal symptoms and make a decision as to whether we were going to prescribe clonidine. We did have a clonidine order set, and that included clonidine and a number of other symptomatic treatments. And we would hold these people in our emergency department or admit them to our short stay unit in the emergency department until they had sufficient relief from their symptoms. Now, this could be, for 3 or more days. In that case, we would be looking to refer these people on to our own medical withdrawal service or community detox programs, or we would be referring them for outpatient follow-up, and ultimately they would be discharged home from the emergency department. So if we look at our data, this graph really demonstrates how we were managing this population in the emergency department back in 2015 to 2016. So this shows the percentage of clonidine and buprenorphine initiations for patients who are presenting to the emergency department in opioid withdrawal. So throughout the baseline period, you can see the number of buprenorphine initiations was much lower than that of clonidine initiations. At that time, most patients were actually referred to other providers to have their buprenorphine started. So we would provide symptomatic management in the emergency department with clonidine, and if the person was interested in buprenorphine maintenance, we would refer them internally or externally. There are a number of other reasons why this isn't 100%. This doesn't include 100% of people. Many people, have preferences about how they want to manage their withdrawal and their opioid use disorder, and some people declined treatment altogether. Some people aren't eligible for buprenorphine, and in some cases, alternative treatments are indicated.
Hi there. So my name is Christine Bukago. I'm an advanced practice clinical leader with a nursing background at the Center for Addiction and Mental Health. I work in the acute care program and support professional practice in the Gerald Sheff and Shanita Kachin emergency departments. Okay, so our objectives when creating the buprenorphine induction pathway order set included the creation of a standardized pathway and buprenorphine treatment protocol for clients seeking help for an opioid use disorder. We wanted the pathway to support a model of care that supports barrier-free and timely access to care so that clients get the right treatments in a timely way. We also wanted to streamline the ordering process to save our clinicians time and prevent errors. As you can see from the graph on the right, over time, the number of clients presenting to our emergency department for assessment has increased. So in 2012, you can see that we had 6,958 emergency service visits. And in 2017, we almost reached 12,000. And these numbers continue to grow. So this being said, clinicians are required to work quickly and efficiently to assess and treat clients given the increase in their numbers. Lastly, we wanted to ensure that the practice and tools created were aligned with and adhere to the new Health Quality Ontario standards for opioid withdrawal. This would mean that we're providing an evidence-based treatment for people with an opioid use disorder in our setting. Okay. In terms of how we selected our solution, order sets provided an opportunity to support practice with technology and to facilitate our objective of standardization. Options were reviewed and selected by the CAMH ED leadership team, the Addiction Medicine Service leadership team. The Addiction Medicine Service is an outpatient addiction service that was partnering with the emergency department at the time. and options were also reviewed with frontline staff. We also had experience with other order sets, such as the ED order set for agitation and aggression, that showed good feedback from staff and data collection that the order set actually changed practice. iCare is our clinical information system and was selected due to a number of factors, including reporting functionality, clinician familiarity, and existing governance and change control processes. Some other benefits of using iCare were that CAMH staff and clinicians were already trained and familiar with the system due to everyday use, including the addiction medicine service. Reporting of current state and future states was already available through existing infrastructure. Communication and automated tasks already existed within our hospital-wide clinical information system. We also had change management, build resources, and governance structures already in place that could be leveraged. And lastly, standardized documentation and practice can be facilitated through workflow and builds such as order sets. So in terms of our interventions, the interventions we implemented were threefold. In November 2016, the ED and Addiction Medicine Service, which is an outpatient addictions program, began a 4-month collaborative pilot project with the goal to improve addiction supports and care patients receive in the ED, increase addiction-specific education for our staff, enhance the transition between the ED and addiction services, and to overall streamline patient flow between our two services. Following the AMS partnership, and based on the pilot evaluation feedback, there was a continued need for addictions and concurrent disorders training. Emergency department staff feedback also indicated that ongoing learning needs, specifically around opioid use disorder, including buprenorphine. We held an ED education rounds for interprofessional staff in April of 2017, while at the same time the buprenorphine induction pathway was going through builds and approvals. The education highlighted that the evidence that when clients with an opioid use disorder are treated with an opioid agonist therapy like buprenorphine within an ED setting, they had better follow-up and retention outcomes and overall used opioids less compared to those who received standard care. It also covered the benefits, initiation, and administration of buprenorphine and highlighted the evidence of a rapid access addiction model for follow-up. So the rapid access addiction model, or RAM, in the CAMH context allows clients to follow up with the addiction medicine service the following business day. The client can drop in during service hours and meet with a clinician and physician for ongoing treatment and counseling. As part of building capacity, staff physicians were also encouraged to complete a training course before prescribing buprenorphine, and the practice lead and nurse educator provided education, including introduction to the iCare buprenorphine induction pathway to 50 emergency department RNs back in May of 2017. Lastly, the order set and pathway was created and built within iCare to serve as technological support for practice. We have around 50 nurses and 200 staff, physicians and residents, plus other learners rotating through the ED who would potentially start a client on buprenorphine or need to monitor clients on this treatment. So an order set made sense to support and standardize this new practice. The order set was created based on best available evidence and best practice, including the use of the clinical opioid-withdrawal scale for assessment purposes, buprenorphine induction in emergency department settings, referring clients to services using a rapid access addiction model, as well as pregnancy and urine drug screening. Based on pilot feedback, there was a need to create a clear and easy pathway from the emergency department to addiction medicine service, and this resulted in the creation of a rapid access referral included in the buprenorphine induction pathway. The order set also includes clinical decision support, mandatory tests, and instructions to ensure standardization of care. So CAMH has a very defined governance process which incorporates end users for changes to the clinical information system. We will outline some of the parts utilized for the buprenorphine pathway. An initial change request is submitted by a clinician to the Integrated Health Record Council, who determines what approvals are required. For the buprenorphine pathway, this request was forwarded to the Order Set Subcommittee of the Pharmacy and Therapeutics Committee. The recommendations of the Order Set Subcommittee were approved by the Pharmacy and Therapeutics Committee and finally approved at the Medical Advisory Committee. More details will be provided on the next slide about these committees. After approval, the pathway was sent to the Clinical Change Advisory Board to facilitate the IT build. At the Integrated Health Record Committee, a clinical request for change resulted in the Emergency Department presenting to the IHRC to identify the initial need and approval for creation of the order set. This committee is chaired by Director of Interprofessional Practice and Director of Medical Informatics and includes clinicians and other stakeholders. The Pharmacy and Therapeutics Committee owned and approved the order set with consultation and voting membership of 6 end-user physicians and 4 end-user pharmacists. As I mentioned, the order set also went to the Order Set Subcommittee, which is a subcommittee of the Pharmacy and Therapeutics Committee. And here, subject matter experts and end users assembled for a deep review of order set build and functionality to ensure accuracy and usability. The Medical Advisory Committee provided approval and recommendations for order set components and functions. Overall, the buprenorphine order set was reviewed in multiple stages of governance by subject matter experts and frontline staff who are end users. So this is our revised workflow, whereby the orange boxes identify where we have utilized health IT to improve our processes. They are also outlined in red. So instead of prescribing clonidine, clinicians are now able to select the buprenorphine order set for treatment, which includes the standardized CAL scale and adheres to the new Health Quality Ontario standards of administering buprenorphine within 2 hours of presentation to an emergency department for clients in active opioid withdrawal. So now we'll walk through the revised workflow. Following an emergency department assessment, if a client with an opioid use disorder is seeking treatment, the team will discuss treatment options with the client. The benefits and the risks of buprenorphine will be discussed, and if the client is agreeable, then the physician would order the buprenorphine induction order set. If not, we would proceed with an alternative treatment. Clients may prefer an alternative and choose not to start buprenorphine for various reasons. They may prefer another treatment, such as methadone, or only prefer counseling, or they may not be at a stage where they are willing to stop using. Also, in order to start this treatment, the client is required to be in moderate withdrawal, and the client may not be ready for that and prefer to begin induction as an outpatient, and so we would refer the client to outpatient services. Once the order set's ordered, the clinical opiate withdrawal scale is completed. If the result is not over 12, we reassess the client in 2 hours. If the result is over 12, we administer buprenorphine and then reassess the client in 2 hours. Sometimes one dose provides full relief, and sometimes it doesn't. So if not, we administer an additional dose, then reassess in 2 hours. If the client's symptoms are relieved with 1 dose, that is the total daily dose that the physician would prescribe, and the client would be referred to the addiction medicine service and be provided with naloxone kit information and then subsequently discharged from the emergency department. What we know is that most people who stop taking opioids without first being stabilized on an opioid agonist therapy like buprenorphine is more likely to relapse. Relapse is particularly dangerous because a person who has stopped taking opioids has reduced tolerance, and they are at an increased risk of overdose and death. Clients who are started on buprenorphine actually experience relief of withdrawal symptoms pretty quickly, usually within 30 minutes to a few hours after receiving the first dose. It also helps reduce cravings for opiates in the long term compared to clonidine. So the experience for clients is so important and factors into retention for treatment, Obviously, clients want to go through the least amount of discomfort. Buprenorphine overall is much safer and much more effective medication to treat an opioid use disorder compared to clonidine and has less risk for overdose. For clinicians and clients, the monitoring period is usually shorter, as clients can be discharged from the ED once their daily dose is established. With clonidine, clients would typically be admitted to the hospital, then to an addiction service to start on a medication like buprenorphine, prolonging the time to treatment. The rapid access referral to CAMH's addiction medicine service promotes continuity of care and provides a pathway for follow-up, as we can safely discharge clients from the ED once their symptoms are managed with buprenorphine. So this is what our buprenorphine order set looks like in eye care, and its features are listed in the top right corner. The order set includes the clinical opiate withdrawal scale, or the COWS scale. It includes orders for vital signs. It includes administration guidelines to select the appropriate dose of buprenorphine, standardized lab orders, the rapid access referral, instructions for distribution of naloxone kits, as well as patient education materials. Once a physician orders the order set, a number of the options are already pre-selected. The physician only needs to select what dose of buprenorphine the client is to receive. And if the client is a female of childbearing age, then the physician would select to order a pregnancy test for the client. This is a screenshot of part of our COWS scale, which is used by nursing staff and physicians to determine when to initiate a client on buprenorphine. So this scale was not being consistently used prior to order set implementation. In fact, it was rarely used, although it already existed in eye care. Typically, clients are initiated when the client is experiencing moderate withdrawal or have a score over 13. The form has automated scoring functionality as well as a scoring key that you'll see on the bottom. Overall, this form takes about 2 minutes to complete. This is a screenshot of our rapid access referral. So as part of the order set, this auto-populates to ensure that clients on this Suboxone induction pathway receive the correct referral, resulting in timely access to continuing care. So now we'll get into the effects of our interventions on the data. So first of all, our AMS partnership created greater clinical awareness and generated familiarity and comfort with prescribing opioid agonist therapy. Our education sessions resulted in the creation of practice guidelines that were used to educate staff about buprenorphine and its use within opioid withdrawal and maintenance therapy. And lastly, our order set and pathway created clinical awareness and enforced regulations to standardize practice for buprenorphine clients and provided a rapid access referral option as part of evidence-based practice. The enforcement of regulations ensures standardized care for buprenorphine patients.
Okay, so we're now going to look at some of the post-implementation data and the value derived from the project itself. So this graph shows the percentage of clonidine and buprenorphine initiations for patients presenting to the emergency department at CAMH in active opioid withdrawal. You can see that after the order set implementation, the percentage of buprenorphine initiations has eclipsed the percentage of clonidine initiations. So you can also see on this graph when our 3 interventions took place. So you might be asking at the end of the day, why are our buprenorphine initiations still only 28%? Well, there are a number of factors that play into our clinical decisions in the emergency department. Some patients may not be stable enough to begin buprenorphine. Some patients may be better suited to an alternative treatment, and some patients may refuse buprenorphine treatment altogether, or they may decline to remain in the emergency department for the necessary period of observation. This next slide shows our readmission rate for patients in opioid withdrawal. So a repeat visit is counted when an individual who visits the emergency department with an opioid withdrawal diagnosis revisits the emergency department within 7 days of the first presentation. And again, the primary diagnosis at the repeat visit is opioid withdrawal. So you can see from this graph that repeat visits for a 7-day period have decreased, demonstrating improved treatment of this population. It may seem like the reduction from 5.31% to 3.96% is minimal in scale. However, to put it in context, for the past 10 years in Ontario, there have been multiple initiatives put forth to reduce hospital readmissions for mental health and addictions patients. Despite all of these initiatives, the rate has remained relatively stagnant. So this small change is actually quite significant if one considers that. The following slide depicts our average wait time between an emergency department visit and follow-up at our addiction medicine service rapid access clinic for patients in opioid withdrawal. So pre-implementation, the average wait time for opioid withdrawal patients between their emergency department and their first addiction medicine service appointment was 9.3 days. Post-implementation, we've been able to reduce this to 4.8 days. The decrease in wait time for this population is imperative to ensure that our patients remain motivated to stop using. The longer the gaps in care, the greater the likelihood that these people will fall through the cracks. So we're now going to look at our return on investment from a financial perspective, and bear with me while I walk you through this slide. So the buprenorphine order set and the education of our staff in the emergency department has certainly led to more effective treatment of this patient population. The rapid access referral, which is part of the order set, has improved access to outpatient services for this patient population, thus reducing our readmission rate, as was shown in the previous slide. So these initiatives have resulted in fewer ED repeat visits and fewer readmissions to hospital for opioid withdrawal. And this is demonstrated as above as cost saved. So the way that we came to these, got to these numbers is by multiplying the cost of an average emergency department visit for these patients, multiplied by the number of emergency department visits, again for this patient population, plus the number of patients who were admitted to an inpatient unit, multiplied by the average length of stay for an opioid withdrawal patient in our hospital, multiplied by the cost of an inpatient day. So the cost savings are both a reduction in ED visits plus a reduction in those admitted to hospital for patients in opioid withdrawal. And this has actually been despite an increase in the number of opioid withdrawal patients that we are supporting. The next slide identifies some soft return on investments that we believe we've benefited from our buprenorphine initiative. So we are now able to treat opioid withdrawal on-site in our emergency department in a very safe and effective manner. That's relatively barrier-free. We have 24/7 access, and patients can choose to be started right then and there without having to make their way to another clinic in the community. We are adhering to the Health Quality Ontario guidelines for opioid agonist therapy, and we've created our own guidelines for our staff in the emergency department. The implementation of the order set and pathway has helped us to reduce repeat emergency department visit rates for opioid withdrawal patients presenting to the emergency department, and has provided greater access to the care that they need.
So in terms of lessons learned, we found that streamlining the ordering process has been very beneficial to our clinicians, and that includes physicians and nursing staff, while emergency volumes increase in our departments. Because as the numbers increase, we need to be able to efficiently and effectively manage clients to ensure that flow through the department is occurring. Another lesson that we learned is that there are ongoing efforts required to ensure that all the people in our departments are confident in initiating treatments, so are confident in initiating buprenorphine or a client on the buprenorphine pathway, and that staff are confident in assessing clients going through opioid withdrawal. We do have many staff and many learners going through our departments, and this is a relatively new practice and a new treatment for everyone, so we're all learning together. Buprenorphine is the most supported treatment through research, but as we've mentioned throughout the presentation, sometimes other medications or other treatments are more appropriate for some patients. For instance, there are other opioid agonist therapies, but that are not as safe to initiate in our setting, which is why we've chosen buprenorphine. But a client might prefer that treatment. Sometimes clients aren't interested in starting on medication per se, but might just be interested in counseling. So there are lots of other reasons why clients might not choose to start buprenorphine. But we do our best in trying to educate clients on the benefits of this safe treatment.
Okay, we would like to thank our speakers for joining us today on this Davies webinar, and remind our listeners where to go find this information and other important Davies use case webinar information and information on how to apply for Davies. That information can be found posted at the HIMSS Davies Award website at hims.org/Davies. That's hims.org/Davies. Thank you for joining us today.